and I will be presenting today. We are in private practice. We're affiliated through a group called DIS Sports and Spine Center, which is a group of surgery centers. I'll give you just a few slides about us. Initially started in 2006, it operates ASCs. Some of our partners and our founder, Dr. Rob Bray. These are the 8 centers we have, predominantly in California, another one in California. And, the goal of our centers is really to provide complex spine surgery and do that in an outpatient setting. So, hopefully we can talk about some of that tonight. These numbers are a few years dated and they're much higher now, but, I feel very fortunate to work at a facility that will allow and accommodate and support this type of spine surgery to be done in an ambulatory setting. And it's certainly not, one person or one institution. There are really entire teams of people behind the scenes who make this possible. So hopefully we can talk about some of that. All that being said, certainly we try to focus on outpatient spine in the centers, but we also understand that there are cases that cannot be done in a surgery center. And so I'm going to actually start out with one of those. So this is a 60-year-old man. He presents to me with bilateral right greater than left radiating leg pain, seems to be in an L5 pattern. Feels like he leans forwards. He can only walk up to about 5 minutes and he has to stop due to pain. His symptoms have been worsening for about 3 years since he had previous spine surgery. Medical history, some testosterone deficiency, occasionally smokes cigars. He's had at least 4 prior spine surgeries, including an ACDF that went on to non-union and required revision. He also had a lumbar fusion that required revision to a T10 to S1 fusion. And he reports there was a dural tear in that surgery. He's done extensive non-operative therapy. He's a very high user of opioid medications, uses Percocet numerous times daily. He's had numerous epidural injections, all with some, but non-sustained relief. On exam, he has some right foot weakness and some decreased sensation in his right leg. Otherwise, some difficulty with walking, but strong in his remaining dermatomes and myotomes. So these are his initial alignment films when he first presented to me. T10 to S1. He's leaning a little bit forward. You can see there he's off about 2 centimeters to the right, 8 centimeters forward. He's got lumbar lordosis, 20 degrees total and 20 from L4 to S1. And his pelvic incidence is around 52. So advanced imaging shows he has haloing of the screws at T10 and T11. And he also has what appears to be a non-union at L5S1. I don't know if you can see my cursor on the screen, but he clearly has patent facets, despite the fact that he has this large, what I'm assuming is this BMP bone formation throughout the middle of the construct. But the L5S1 level doesn't have fused facet joints. And I do think there are some lucencies that you can see around the S1 screws. At least at this view, I think the L4-5 level is well fused. So MRIs, tons of artifacts. So a little difficult. Maybe you can make out some foraminal stenosis at L5 if you think you can see anything. Does not have osteoporosis. So this is the presentation. T10 to S1. He's had a prior posterior lumbar fusion. He has pseudoarthrosis at T10 and 11, and I believe also at L5S1. He's got sagittal deformity with a positive SVA of 8 centimeters. He's got PIL mismatch of about 30 degrees. And he's got lumbar radiculopathy, which is on the right side at L5 and S1. We do have an EMG that shows that as well. So that's the presentation. I'd love to hear any thoughts on how to sort of approach this revision case.
Hi, good evening, guys. Sorry I was late logging in. Obviously, this is a big boy surgery, with probably to get this patient better, going to need a major revision. I agree with you that the bottom level does not look fused. So you have, pseudos both up top and below. So seems like it's something that's, Could you adequately decompress the foramen from the back without an interbody? Perhaps, but then you also have the lumbopelvic mismatch, which, L5S1 is going to be the most powerful way to correct that. I think most people would choose the front. I forget if I might have missed the beginning part. Were there any contraindications for anterior approaches?
He's had no prior abdominal surgeries, no obvious aortic calcifications, anything of that nature. So,
Yeah, this is a tough case. As you said, Brandon, you might consider doing a foraminotomy and, unfortunately with the long fusion may not work. And then, as you said, it's a big boy. So it's got to be osteotomies, try to correct the mismatch. This is a big, big surgery. And I know that our deformity guys would probably do a couple level osteotomies just to try to get that lumbar lordosis increased, especially at 5.1 and 4.5. So it's a tough one. So you don't know anything about the previous surgery. Obviously, they fuse them with a flat pack, but
The first surgery, he was very vague on when it occurred and what it was. And then I had the operative report for the surgery that was about 3 years ago, which was the T10 to S1 fusion with the dural tear. The prior back cages, which are at 4.5 and 5.1, were from his index surgery sometime before 3 years ago.
I guess the one saving grace is that the patient didn't have a sacral fracture because I don't know if you've had the pleasure of treating any of those, but that is the very, when the patient has the flat back plus uh, S1 becomes kyphotic because of the long lever arm and a fracture, that's, then people are, from what I've never had to do this, fortunately, but, generally discussed, you're going to need to start doing osteotomies at S1 to try to get the base of the spine realigned. So I guess that's the one upside of this case.
Yeah.
Good evening, everyone. Sorry I got in a little late. It's Izzy.
oh,
Perfect.
thank God you're here,
Hi,
Izzy.
good evening, Dr. Lieberman.
Thank you, Izzy.
You're very, very welcome. Yeah, this is, as you guys know, my dime a dozen type case. The one thing that I become very committed to and religious about is staging these cases. It gives you an opportunity to get to know the patient, gives the patient an opportunity to get to know you. You've got a host of problems there. But the first stage, what I think is probably the most important, is setting yourself up. You take out all the hardware that's in there, you culture everything up. We're now up to, on our revision cases, up to 40% of them have an occult infection, of which over 75% are C. acnes right now. So I wouldn't be surprised if this guy was growing out some bugs as well, especially when you see those big giant holes where those screws are. Once you've got all the hardware out, then you can rebuild and decide which way to go. And yeah, he's going to need something at L5S1. He's going to need some kind of osteotomies. I wouldn't want to do pedicle subtractions on him. I'd probably try to do multi-level Smith-Pete's. If I look at the films, I think he got some good mobile discs at 3.4 and 2.3. So if you just do the fusion mass or Smith-Pete type osteotomies with a good L5S1 interbody, you should be able to get him back some semblance of lordosis, and then decompress whatever nerves need to be decompressed. But staging, that's my contribution here. Stage it 2 stages, 3 stages, don't rush with it.
And I had a question about that because I've heard you discuss this approach before, Dr. Lieberman. When the patients are in between the removal and their next surgery, how do they fare in terms of? I would imagine if they don't really have a stable fusion, that they'd have a lot of trouble mobilizing. But it sounds like perhaps that's not the case. Do you give them braces, or how do they do in between the first stage and the rest?
Look at the images on that last case. Those screws are all loose. That spine isn't really moving. What's happening is the screws are pistoning in and out of the holes. That's what's giving them the pain. 30% of the patients whose hardware I remove come back to me and say, you know what, I'm good enough. I don't need anything else. Brilliant. You've solved their problem. They're done. Next case. But the other 70%, need something done. And I don't give them any brace or anything. They're on antibiotics for 6 or 8 weeks most of the time because they do have an occult infection. I work them up again with CT scans, and they're not that limited. They really don't notice that much of a difference in terms of their function with the hardware removed.
Good to know.
I have a question about your, you mentioned L2-3. I mean, do you have concern when you're thinking about osteotomies that high in the lumbar spine about, placing lordosis at a place that it, otherwise ought not be, sort of creating lordosis that's not anatomic or, not the way it should be?
Well, you know the answer to that by virtue of asking the question. Of course, you're concerned about it. And that's why you get the full length standing x-rays and you determine exactly how much lordosis you need to keep them balanced to restore the native thoracic kyphosis, which should be a reciprocal restoration to what you have there. But I concentrate on the pelvis. I want to get the pelvis in neutral and then let the rest of the kinetic chain align itself as best you can. And I just estimate. And sometimes I get it on, other times I've over lordosed them, other times I've under lordosed them.
Yeah. All right. So I think plan, we, all posterior revision. Sounds like most people didn't like that. PSO, Dr. Lieberman, you hated that plan. Why did you hate the PSO plan? Is that because it's non-union or what was that?
I just don't like dealing with dural tears. That's all. To do a PSO in a previous fusion bed where they've had other decompressions, you're dealing with scar. You get through one level, you get a dural tear, you're cursing, you're doing the one of my former mentors used to say, shit on my head dance. And then you go to the next level and the same thing happens. So I just try to stay away from PSOs as much as possible. If I've got mobile discs, I'll use Smith Pete's, and then if it's a big enough gap and on the post-op standing x-ray, the sagittal vertical axis falls in front of the spine, then I'm filling that gap in front with an inner body. Most of the time it's a direct lateral. If the sagittal vertical axis is lying behind the level where you've got the lordosis, I leave it be. It's going to fuse.
So thank you. So my goals for this surgery were, like we've talked about, restore alignment, make sure he fuses, and try to attempt some sort of decompression to address his radiculopathy. So this is what we did. Didn't have osteoporosis. He completely stopped cigar smoking for 3 months. I did send him to endocrinology. He had normal evaluation. He completely stopped his narcotic utilization. Then he had a dental infection with an abscess. So he was on antibiotics, and we postponed the surgery for about 6 months before proceeding. So this is what we plan to do. Kind of similar to what Dr. Lieberman had mentioned. Day one, remove all the instrumentation and do true Smith Pete's, 3 of them at 3, 4, 4, 5, 5, 1. Day two, go to the front, try to take out the back cages at 5-1, place a hyperlordotic ALIF. Consider doing some sort of ALIF at L4-5, although I'm quite certain that level is quite, it's very fused. It appears to be on the CT. And then a 3-4 ALIF as well. Then on day 3, lock it all down. I will obtain imaging after the second stage and see if we need any additional lordosis, and let that imaging sort of, determine the final stage of the operation. So that was the plan going into surgery. This is after stage 2. You can see, I'm not sure again if you can see my cursor on the screen, but you can see the Smith Pete's with the osteotomies that we completed at 3, 4, 4, 5, 5, 1. The back cage at 5-1 came out relatively easily, and we put a hyperlordotic 28-degree ALIF in there. And then this is a 17-degree ALIF. Here's the CT images showing that Smith Pete's and the amount of decompression that was done. So it's the before and after. And this is what we came to after day 2 of surgery, is the lordosis was measuring about 40 degrees. And so we felt that we didn't need any additional osteotomy, and that with some compression through the back, we could obtain the remaining lordosis that was necessary to get rid of the mismatch. So these are our final x-rays, and these show the alignment. We ended up with about 47 degrees of lordosis.
It's awesome.
Yeah, I think I was pleased. You know, it's a little bit, a lot of options for these surgeries, and it was definitely, like Dr. Lieber mentioned, sort of a slow process with a lot of thinking, even in the middle of the surgery. And it certainly was not without complications, you know, during and after the surgery, which I'm happy to talk about. So, like I said, stage one, we removed the hardware to true Smith-Peets all the way across with bilateral facetectomies at 3-4-4-5-5-1. Then we did a large decompression on the right side to address his radiculopathy. In addition to those, put the ALIFs in at 5-1 and 3-4, and then use a patient-specific rod and extended, just due to the haloing at T10, extended just one level to T9, and then placed 4 sacroiliac screws into the pelvis. And this is a picture intraop of his closure, and the plastic surgeon did take 3 hours for closure, which was, you know, one of those cases. I was very thankful he was there. So, you know, some of those complications, what were they? After the first day of surgery, he was admitted to the ICU with rhabdo, which had resolved by day 2. But the thought there was due to the medications he received from the anesthesia. After the stage 1, he also woke up with some left quad weakness, really 2 out of 5, and a pretty dense numbness in his left anterior thigh. This did require a neomobilizer initially in the hospital, although this is pretty rapidly improved now to 4 out of 5. He does still have some numbness. He was in the hospital about 6 days, discharged to rehab. His right lower extremity radiculopathy had, you know, completely resolved. So this is one of the many papers just looking at complications in spinal deformity surgery. This paper, you know, said it was up to 65-70% of patients who undergo this type of surgery are going to have some sort of either medical or surgical complication during their course. So, you know, the biggest thing for me, I mean, other than thinking about it, was really dealing with the quad weakness that, you know, I caused. And my suspicion is, you know, on the right side, you can really see how narrow that L4 foramen is. On the right side, we did quite a big decompression there. So on the 3rd day of surgery, we went and explored it and used the pedicle screw stimulator to actually explore the nerves L3 and L4, given his quad weakness. And the nerves, I mean, we traced them all the way out. They were in continuity. They were firing. And so, you know, we did an additional decompression at that left L4, put steroids on it, gave him oral steroids short term right after the surgery. And thankfully, he, you know, substantially improved, but it's not yet back to baseline. So any thoughts on those things or managing those complications?
Those are expected complications. Anytime you're around the nerve roots and this type of revision phenomenon, especially when you're working around the dorsal root ganglion, they just do not like it. One nerve root, you can stretch across the room and you won't have a problem. The next nerve root, you just wink at it and you've got a palsy. So I don't know how to explain it, but I've certainly had to deal with it. And I deal with it the exact same way you do, short of the steroids. I don't know that steroids really give you anything with that.
Yeah. All right. So moving on. The next case, we have a 63-year-old gentleman. He came in with right thigh and shin pain, numbness for about 6 months. Had a prior ankle fusion about 20 years ago, and had a provoked DVT and a PE on Eliquis. Otherwise, he's managed this pretty aggressively with injections, therapy, medication. He's got a little bit of weakness in his foot and some otherwise normal sensation, some difficulty with heel walking. These are his x-rays that show a pretty decent L4-5 spondy, you know, significant spondylosis around the facet joints that you can even see on the plain x-rays. MRIs show, large right-sided facet cysts, facet effusions, facet spondylosis, some foraminal stenosis, not a ton, really isolated to the 4-5 level with clinical L5 radiculopathy. So again, pretty substantial facet arthrosis. This L5, this big 4-5 facet joint on the right side, I think is pretty impressive. So I think, it's a case that we all see pretty much, maybe every day, 4-5 spondy. Unique things about this case that may be a little different than every 4-5 degen spondy we see, or a large facet cyst and the amount of spondylosis he has. So with that, I'd love to have just sort of a conversation about, best plans to address this, pretty common problem that we see every day.
The picture you have right there, that's an axial cut through the 4-5 disc, I presume.
Yes.
So you're looking at your 4-5 facet joints there. And what strikes me as very interesting is how coronally oriented those facet joints are. I'd want to see a CT scan on that. Do you have the? Yeah, you see, they're very coronally oriented. Now the other thing is the subarticular region at 5-1, which may be irritating that 5 nerve root as well, but it looks like it's just the 4-5 level. So how active is this guy?
He's actually very active. He is a big guy, overweight but not obese, but he plays golf 3-4 times a week. And every time I talk to him, he is talking about how his leg pain is preventing him from playing golf. And that is extremely debilitating to him.
Yeah.
So he cycles and he plays golf.
So this is an individual that I would probably recommend. Now I haven't seen him or anything, but I'd probably recommend a decompression first. Midline, bilateral decompression, foraminotomies, decompress the subarticular zone, and rehab him and see how he does. I'm not that concerned about the instability at that level with the coronally oriented facet joints. And I think you can do strategic decompressions and cuts there and see what happens. If 6 months down the road, a year down the road, the mechanical pain is so bad and he does develop some instability, then you can go ahead and do the bigger operation and the fusion. And I'd probably end up doing an ALIF on him with perk screws, knowing that I don't have to go back and decompress him. So here's another one that I think we jump to the conclusion that everyone needs to be reconstructed and fused and this. But here's one that I think you may get away with just a decompression on him.
And the other thing, Steve, looking at his x-rays, do you think it's a cyst in the neuroforamen, or do you think it's a soft disc? I mean, he does have a synovial cyst, but...
And the foramen? You mean this right here?
Yeah, right there.
Yeah.
It doesn't matter what it is. You're decompressing it.
No, I know that, Izzy.
Yeah.
But, what I was thinking is that, we have some partners with endoscopic, skills that, I don't know if it'd be reasonable, but.
So my concern doing this endoscopically would be the subarticular stenosis that you see there because of the coronally oriented facets and those osteophytes. So that traversing L5 nerve root is probably being irritated by that subarticular stenosis. So just dealing with the foraminal stenosis here, he may still have pain. He may still have L5 symptoms as opposed to the pure L4 symptoms.
Well, didn't you say he had anterior shin pain, Steve?
It's predominantly lateral. It really seems like a clinical L5 to me.
Okay.
Not so much anterior shin.
Right. So
more lateral thigh, lateral shin.
So the foramen at 4-5 is not that critical, but I still wouldn't leave that. I would decompress that subarticular zone and see what he's like.
Dr. Hirsch, what do you think about endoscopic here? Dr. Hirsch is a very good
Um, I think, it's very challenging to decompress the lateral recess subarticular region with a transforaminal approach, but you can do it. You just have to take out a decent amount of the tip of the SAP. So it's not wouldn't be like a beginner type of case for endoscopy. I have, similar thoughts and go back and forth on decompression versus fusion for these slips that have, some subtle signs of instability, but aren't frankly, unstable, don't have a ton of foraminal stenosis. And I often will have discussions with the patient about what their preferred approach is. I sort of present them, there's an option where we do what Dr. Lieberman mentioned, and we see what we can get with a decompression, but we understand that may need to go back and stabilize it if symptoms recur postoperatively. And certainly in our market in Southern California, the word fusion is like a cardinal sin. And the minute you start talking about fusions, patients get very apprehensive. Sometimes I wonder if I'm just giving too much information and making the patients more confused. I'm curious, Dr. Lieberman, Dr. Geyer, you've been doing this a long time. What are your opinions about the shared decision-making aspect in these patients with stenosis and a subtly unstable, questionably unstable spondylolisthesis about involving the patient in the decision-making?
Well, I think that's always important, Brandon, because as Izzy pointed out, his coronal position of the facets, even though they're a little widened, so he obviously has a little bit of motion. If his main complaint is his leg pain, it's not unreasonable, because if you end up doing a fusion there, his facets at 5-1 look pretty crappy too. At least is what I recall. And even at 3-4, they look crappy. Not that I'm saying you should go up to 3-4 and then down to 5-1. The 5-1 disc actually doesn't look bad, but once you do a fusion and his age, he's probably going to burn something else out. So I think it's not unreasonable. You talk to him and say, hey, look, we can do a decompression and fusion. The problem is that you may have a problem above and below, but at your age, hopefully not. Or we can just do this, and understanding that, it may not work, but you might, if it works, then, you're a big winner. So I always try to involve the patient, at least let them understand if I, once do my recommendation. But my final recommendation is the family test. In other words, what would I want done for me or a family member? And I usually say that, and makes them feel better, and because it's true. That's how I do make my decision.
Yeah. Oh, I love this discussion. I mean, I think in the past year I've decompressed more spondies than fused them. I'll give it away now. I fused them. But the reason I did that, and I'd love to hear thoughts, are number one, I agree. I think he needs direct decompression with the facet cyst. I wanted him to wake up and say 100% of my leg pain's gone. Number two, I really like the discussion about the facet orientation, but still the fact that there is such a large effusion in the presence of the facet cyst makes me worried that even micro instability may be more than we can really appreciate on the flex x-rays. So for those reasons, I chose to fuse him. But I think these are all, great points. And I love the idea.
But Steve, it's not wrong. There's not a right or wrong answer.
Yeah. But I think there ends the utility of these discussions. I love it.
I think the last thing I'll just mention is Mark Kramer checking in from Seattle. As a disciple of Dr. Chapman, I have to mention that a lot of arthritis along the spinous processes kind of consistent with like a Bastrup's disease. And Dr. Chapman and I've kind of agree with him. This would be a good case potentially for the Coflex interspacer device. And although these things may not be durable for decades, it may buy them some time before you venture into fusion in these cases.
Mark, I'm glad you mentioned that, because Jens does love the Coflex, and you're right, he probably would have done a Coflex in this situation.
Well, with all due respect to Jens, that's just lunacy. He's
No, it's not lunacy.
lordotic there. You're going to be pitching him into kyphosis. You're taking
No,
the
you're not. No, you're not, Izzy.
instantaneous axis of rotation, moving it to the posterior aspect of the spine. You haven't addressed any of the structural stenosis that's there. This we're talking about revisions. I've had the privilege of revising many of those, and this is not one that I think would be amenable to a Coflex. It would be very, very
Far and away, the most important thing is decompressing the nerve roots. Absolutely. So that's paramount. The Coflex interspacer stabilizing device is secondary to that, but and agree. If done poorly, that would not be a good solution for any patient. But if done correctly, I've seen success with the device.
Great point.
Right. Yeah, thank you. I agree. Great discussion points. So I think we've
Listen, in defense of Jens, who's not here to say anything, I think that's an option for him.
So everything from decompression to Coflex to ALIF. So what did I do? I did parentheses, quotes MIS TLIF, wanted to directly decompress the nerve root. I don't like TLIFs. I really like ALIFs and laterals for all the reasons that we all do. He did have some aortic calcification. He was a bigger guy. He still could have done the ALIF in the lateral, but it doesn't get me around the fact that I wanted to directly decompress these. So this is what I did. I think it looks okay. That TLIF inner body is very narrow, but he woke up. He felt great. These are the 2-week post-ops. I think that the TLIF inner body has subsided a very small amount. Which is, one of the many reasons that I'm not in love with TLIFs to begin with, but it did achieve the goals of the surgery in this patient. So it took me a little over 2 hours. I made 3 incisions, a midline, as well as 2 paramedian incisions. Pros and cons of the 3 incisions, probably harder to heal, a little more pain, but he had 100% right leg pain. So wanted to use that left, interlaminar space, decorticate the lamina and put bone graft all over the left side, hopefully to promote fusion.
Dave, do you think you could have gotten a second graft or TLIF graft and scooted it over, or is it just not possible?
Possibly. The way I did the surgery is I essentially made a midline incision where I did the TLIF from the fascicectomy and the TLIF. And so I didn't have a very large lateral window to essentially drop your hand and get a banana-shaped cage really far across. I, probably could have done a slightly better job getting it more midline. Definitely one of the downsides, I think, of doing it this way versus, if I had done Wiltses and done the fascicectomy through a Wiltse, would have had a better angle for that. The downside to that, in my opinion, is that I couldn't get as much bone graft where I did. So.
And what did you pack? What kind of bone graft did you pack in there?
I used BMP in the inner space and then graft on.
Okay. Yeah, it's just that's a lot for that single graft to hold up, even with your pedicle screws. So.
I agree.
How far out is he now?
He's about a month out. So we will see. Maybe at the next one, I'll let you know.
Yeah, hopefully, he won't get much more subsidence, but
yeah, with the subsidence, certainly, fusion can be impacted, which I think would be the main concern. Again, I don't think clinically he had an L4 radiculopathy, although, the L4 on the right side should now be fully decompressed. With the removal of the facet cyst, his L5 radic went away. So anyway, this was done in the surgery center. He did go home. He stayed overnight, went home in the morning, 23-hour stay. He was ambulating unassisted. His right leg pain had fully resolved. He had some incisional back pain. Pros and cons, like we've already been discussing, I wanted direct decompression, and he had immediate complete resolution of his leg pain. I think this approach gave us a good surface for a fusion, especially on the left side from lamina to lamina at 4 and 5. 3 incisions versus 2 is probably slightly harder for the post-op recovery. The TLIF, I mean, this is what we were just saying with the subsidence and the fusion rates. Does it have a lower fusion rate? Maybe it's not fully borne out, but I don't know if I believe it. I have this little, I'm sure you guys have seen this paper in the British Medical Journal showing that parachute use when jumping from an airplane has no outcome on mortality. And then this is the picture they have in their published paper, which is someone jumping from ground level. So just because it's not out in the literature doesn't necessarily mean I believe it. So I certainly think that a larger antibody with an ALIF or lateral probably has less subsidence and hopefully a higher fusion rate. But overall, the patient is currently doing very well. So happy patient at this point.
Izzy, what would you have done?
Thank you.
I would have decompressed them alone.
And if he came back and said, I'm still hurting?
ALIF and perk screws.
But
I like
Steve
that
said he
one.
had a pretty big belly, and did you say he had calcification too? I'm not sure.
No, I don't think there was any contraindication to an ALIF. I just wanted direct decompression, and I thought an ALIF with screws and decompression all at the same time is a lot of surgery. But as I showed in the last case, I like a lot of surgery sometimes. It's a very good solution. Maybe I'll do that next time.
Let me bounce that off you, Rick. The family test. What would you have done?
I think I would have done the decompression first and probably done the ALIF with perp screws if he failed.
We must be cousins.
I think
we
all
are.
all valid in my opinion.
Yeah, that's right. We think alike.
All right, a lot of good thoughts. So these
All
are
right, Brendan, you're up.
All right, Steve's going to operate the slides for me, but this is a very nice 53-year-old woman with L5 radiculopathy as well as back pain for many years. She had really tried everything, had physical therapy, worsened her symptoms, 8 out of 10 back and right leg pain and L5 distribution. You can go to the next slide. As far as her past medical, she had a prior abdominoplasty. She's familiar with spine surgery from a pretty significant posterior cervical operation, self-employed. She had a bad experience with injections. I sort of waver on how hard I push injections in this kind of case, and you may see kind of why and when I show the MRI. But she had a bad experience. ESI wasn't really on the table. She wasn't really willing to consider it. As far as her exam goes, normal exam except for some mild right EHL weakness. Otherwise, she's well balanced. Those are her FlexX films on the bottom there. So she's got a adult idiopathic curve with the apex at L3 with the 4-5 slip and some pretty significant amount of asymmetric disc space collapse at 5-1, which we can throw the MRI up. And Steve, if you can just go ahead.
Let's go back for a sec, Brandon. Why are you calling this an adult idiopathic curve?
Because of the rotation, and I don't see a lot of asymmetric disc space collapse throughout it. So I don't know whether it's adult degenerative scoliosis or adult idiopathic. When I see rotation like this with relatively preserved disc heights in the middle and upper lumbar spine, I tend to think that's probably a curve that's been there since she was a teenager.
You see, I wouldn't even label her as a scoliosis. I think what you're seeing is a reciprocal response to the 4-5 spondy. And as soon as you straighten out the 4-5 spondy, all that stuff above is going to straighten itself out.
We will get an opportunity to look at that, and I agree with you. So the MRI, Steve, you can just run through and kind of go back and forth. Basically shows that she's got. I don't know why that didn't project correctly, but she has L4-5 lateral recess stenosis. I'd had some cuts of L4-5. I apologize, but she's got pretty decent sized faceta fusions. With 4-5 lateral recess and pretty significant foraminal stenosis. I had foraminal cuts on there, but it must have just got sent the wrong file. But she has pretty significant right-sided L5S1 foraminal stenosis. I didn't think that was something that with that asymmetric disc degeneration, that decompression alone for her 5-1 foramen was going to be satisfactory. Apologies for the open MRI quality; those are also pretty popular here. The CT scan, shows pretty cruddy looking facets at both levels with vacuum discs and foraminal stenosis on the right at 5-1, almost pedicle to pedicle there with that end plate osteophyte. So I think this is an interesting case around focal treatment of adult scoliosis when you have a fractional curve that has foraminal stenosis. This also has a 4-5 listhesis with lateral recess stenosis. Dr. Lieberman, I'd be curious to hear your thoughts as someone who does a lot of complex surgery about treating focally based on the nerve root signature and the radiculopathy and the stenosis rather than trying to have a perfect alignment. There's no sagittal imbalance, issue here. I don't routinely get full length films, so I don't have that to show.
I rely heavily on the full length X-rays, as you guys know. I'm an advocate, a proponent, an evangelist for symptom specific surgery. What are her symptoms? What are you treating? In this case, yeah, you're treating a deformity, but my impression of this case is the deformity is at that 4-5 level. It's not a global lumbar curve, whether you want to call it adult idiopathic or degenerative scoliosis, whatever. It's a reciprocal curve on the basis of the degenerative changes at 4-5. Having seen 5-1, yeah, that's probably contributing to it on the basis of the stiffness of that level. Those facets aren't moving, the disc isn't compliant. So in my hands, she's getting a 2-level lumbar reconstruction, symptom specific with respect to the nerves that she's complaining about.
Mhm. And what are your thoughts on direct versus indirect decompression? I know we couldn't. I apologize. The axial 4-5. I'm not sure why it didn't make the slides, but she's got pretty significant lateral recess stenosis, but no obvious cyst.
Yeah, I think that becomes case specific. I rely heavily on indirect decompression. So I'll do 2-level A-lift, perk screws, and explain to the patients I plan to try to get as much opening for the nerves indirectly. If I can't, I bring you back for a focal decompression, which is not a big operation, which minimizes the risk. And you've got a good chance of relieving a lot of your nerve pain. Now, the one thing I'm concerned about, especially on that cut there, where I'd probably err on a direct decompression, exactly that little beak on the bottom of L5. When you distract that up, you're taking that L5 nerve root and the dorsal root ganglion, and you're squeezing it back through that little area. And that gives them a lot of pain. And it does this, what Ian McNabb used to refer to as the pedicular kink. And you've gotta look for that.
Yeah, those end plate osteophytes have tortured me in my first 8 years of practice, and I still go back and forth on does that mean I need to take the facet off? What are your thoughts about anterior foraminotomies? There's people talk about it. There's maybe like one case series published in Asia of them doing a foraminal decompression of these osteophytes during the ALIF.
So it's funny. In the cervical spine, we don't hesitate. In the lumbar spine, we do. And I think it's just a matter of dimensions. In the cervical spine, you're working in a small dark hole. Your excursions are in the millimeter range. In the lumbar spine, you're working in a big, deep, dark hole. Your excursions are in the centimeters. So I just don't like that idea. In this case, if I'm doing an A-lift, I wouldn't hesitate to take the facet joint off and to look at that osteophyte. And I'm a big fan of the ultrasonic bone removal technology. I'll use one of the ultrasonic hooks or cobs or even the ultrasonic scalpel and just shave that beak right off of there, and then make sure that I can get the ball tip probe around the nerve on both sides, from cephalad and from caudate, and run it up and down and make sure it's nice and free.
You know, Brandon, doing artificial disc, sometimes we'll get these little osteophytes, and I'll take the Curacin. The problem is that they don't have long enough instruments. They don't have instruments that are curved enough to really get them effectively. Sometimes I'll take the angled curette and I'll try to get it out there. But unfortunately, you're right by the ganglion. So I'm really reluctant to do a lot of work out there because you bang, as Izzy was saying before, you bang that ganglion and the patient's not happy.
Yeah, appreciate it.
And the other thing that I'll say that you know, since we started doing a lot of facet injections, uh, I'm sorry, my phone went off. Since we started doing a lot of CT scans before the disc replacements, we see that there are a lot of these spurs, and there have been some patients that I've done the disc replacement on. They get the post-op and nurse rest, and then I do a CT, and I go, "Oh my goodness!" Fortunately, I've not had to go back and decompress them. Usually, you can manage them conservatively. So,
yeah,
and I always tell a patient that when we do this, we may have to go back in and decompress them from behind. But knock on wood, I've not had to do it. So, you know,
yeah,
and what Izzy said is all true about kinking of the nerve root. But for some reason, um, I guess maybe I've been lucky,
yeah.
but I do worry about it.
All right. Thank you. Yeah, so we did what Dr. Liebman referenced with a two-level front back, relied on indirect decompression. We were able to do this at the surgery center. We have 23-hour stay capability and a great perioperative team, extremely skilled vascular approach surgeon. And she did quite well. She did have a brief, what seemed like a neuropraxia with painless EHL and Tivant weakness, but gave her some steroid overnight, and by the morning when I checked on her, she, you know, the strength had pretty much normalized to at least a 4 plus. She was able to go home. Actually saw her today for her 3-month visit. She's very pleased. Has some minimal back soreness, leg pain's gone, so she's very happy.
And you didn't do a direct decompression, did you?
I
Yeah.
didn't. I didn't.
And see that's been my experience as well. You see those little spurs, you get nervous about them, you tell the patient about them, and knock on wood, you know, just like you treated her with the medication, they
Yeah.
do okay.
Yeah, unfortunately, I've had other cases where, you know, there was weakness and pain that persisted and forced my hand. You know, I've learned a little bit in my early practice to, you know, try to be patient and give it the tincture of time.
The buzzword there, Rick, was stay nervous about it. Don't
Yes.
forget about it. Just stay
No,
nervous
and that's
about
absolutely right. Is he
Yeah.
absolutely right?
Yeah, awesome. All right, we'll try to get this last case in. I know we're coming up on the end. Go to the next slide. So this is a 62-year-old male, worsening back and bilateral leg pain, had a Coflex placed about 10 plus years ago, and that had helped him for a good 8 years before he started to gradually have a recurrence. By the time I saw him this year, between the first time I saw him when the pain was somewhat bothersome to the next visit, he had sort of become incapacitated with back and leg pain, couldn't tolerate physical therapy, had a remote history of an epidural with very short-term relief. Go to the next slide. And these are his x-rays. He's got the 4-5 slip there. Certainly moves in my opinion. And then as far nothing really in his past medical history that's remarkable. His exam was normal. So why don't we go over to the MRI? So this is MRI, very severe 4-5 central and lateral recess stenosis. Freeman, moderate, but not critical. I think my theory is if you look at that central disc herniation, I think that's what kind of tipped him over the edge. Is he had this 4-5 slip and stenosis, he was doing okay, and then he popped that central piece of that disc up behind the body, and that pushed him over the edge. And then
Brandon, can you just go back to his x-rays for a moment?
Yeah.
What was his main complaint?
It was both back and bilateral leg pain.
Are his hips okay?
He's got hip arthritis, but no anterior groin, and this was full radiculopathy going all the way down the leg.
All right.
So CT scan will show, he's got the Coflex in place, a little bit of lucency, arthritic, facets, but not much else. So I sort of, had decided this patient probably should have a fusion procedure. He has this residual spondylolisthesis, has had a decompression, a Coflex. I didn't think he would really have an appetite for doing a revision decompression, and then if that didn't work, going back then for a third surgery. But curious, Dr. Geyer, Dr. Lieberman, how you look at these cases and how you decide on fusion or not.
Well, they tried the conservative treatment. I think that, you to go in there, it's going to be lots of scarring. And my feeling is that I think that if you go in from the front, or, my preference would be to do that. If you restore his disc height, you're going to get all that posterior disc out. You'll do an indirect decompression. And I'm not even so sure I would take the Coflex out and then do perp screws, to be honest with you.
Yeah, that was my second question, was Coflex removal.
Yeah, I mean, on the one cut that you had in the CT, it almost looked like there was bone inside, but that doesn't mean that it's fused. And you'll get it. I'm sure it'll move when you do the ALIF, because
Dr. Howard, you said all indirect decompression with this. You wouldn't go back in and decompress.
As Brandon showed in that view right there, you can see the central herniation, and that has really narrowed him down. And I think if you can reduce it, and you'll stretch out the PLL, you'll get the residual disc, you'll give him a heck of a lot more room. It looks like on the right side, there's really not much ligamentum flavum. There's a little bit on the left side. So, I think you do fine. I mean, I wouldn't fault anybody for doing the direct, but you know, that's just my view.
I worry about these discs. I mean, there's some disc degeneration there, but it's I don't want to say it's a healthy disc, but it's not a completely collapsed disc. And so relying solely on the indirect and a disc that's still, I mean, there's still at least, I don't know, 7, 8, 9 millimeters there of disc height. You're going to have to really hope that the amount.
Well, if you look at L5S1, L5S1 is probably the most normal of all his disc. I think he has, some collapse at all the proximal disc as well. So, and I'm not saying to use the humongous cage, but I hear what you're saying. I think you can probably get enough. It's like, how many millimeters decompression do you need? And it's like a little silly millimeters what pushes the patient over the top.
Yeah. Any opinions, Dr. Lieberman, about the Coflex and deciding on fusion, Coflex removal?
I must admit, I'd remove the Coflex more for selfish reasons, that the X-ray would look awfully bizarre, and I wouldn't want anyone to say, "Look what Lieberman did. He put a Coflex in and pedicle screws." And yeah, I'd still try to rely on a direct decompression in this. If you look at that cut there particularly, you can see he doesn't have an adequate sublaminar decompression there. Yeah, you get him some room from in front. How young is this guy?
He's 62, but he's a very fit, Southern California 62.
Yeah, so I debate this one, whether I'd stage it or not. Do the ALIF first, give him a couple days, see what his symptoms are like, and then bring him back to do the posterior, either perk or do the direct decompression and open him up. But yeah, I'd have to see the patient to decide which way I'd go with it.
Yeah. All right, Steve, you can show the post-op. So yeah, so I relied on, it's sort of indirect and direct. I did go all the way back to the PLL and fished out, a large fragment. I was able to pass nerve hooks up behind L4. I was pretty confident I got that central disc. And then we got a really nice sized cage and a nice reduction with the screws, and I sort of debated it and asked around, should I take this Coflex out? I didn't think of what other surgeons in the community would say seeing the post-op x-ray, but
Oh
maybe I
my
should.
God, look what Dr. Hirsch did. He
Yeah,
put a
yeah.
Coflex in and pedicle screws.
Yeah, well, but fortunately, he did very well. He's minimal back soreness, no leg pain. Saw him for 6 week follow-up, no pain medication. We were able to do this at the surgery center, and send him home in the morning. And so, um, yeah, I was pleased with this, and perhaps it's evidence that we don't necessarily need to take the Coflex out unless we're worried about the cosmetic part.
And Brandon, you did a great job, except for your ugly X-ray, leaving that Coflex in. I'm kidding. I'm kidding. I would have done the same thing.
Yeah, yeah.
Izzy would have taken it out because he's
He-
afraid of what we would say.
Yeah, could we see let's see his original X-ray again. I want to look at that L5S1 level on the original. So yeah, this is interesting, and this is something that I see. Look at the Flex X films and his neutral lateral. Look at the lordosis he has at L5S1 right now, the way he
Yeah.
is before. Now go to your post-op films and look at the lordosis at 5.1.
Yeah, certainly seems to have flattened out a bit. So
Yeah.
theory is it's compensation on the pre-op film.
No, well, maybe it's compensation on the pre-op film, or what we've done post-op is forced him into kyphosis at 5.1. And this is one of the things that I'm starting to pick up. There's a dynamic analysis program that I'm using to look at the levels above and below previous fusions. And we're noticing with degenerative 4.5s, you're amplifying the load on the 5.1 facet joints when you restore the listhesis and the lordosis at 4.5. And I'm trying to figure out why we're doing that. Intuitively, you think, well, we're restoring the anatomy. We shouldn't be amplifying the loads there. But we're doing something to amplify the loads at that 5.1 facet joint and tip them into kyphosis there.
Well, Izzy,
So
do you think it has anything to do with getting the precise size? Now, what Brandon gave him, nice lordosis. You could argue that compared to the levels above, perhaps he's distracted a little, or she's distracted a little bit too much. But again, that's something we do all the time. But it's an interesting observation.
yeah,
So,
and
the
again,
question is, if it was a millimeter shorter, would it have made a difference in height, both anterior and posterior? I don't know.
I don't know the answer to that, but I'm bringing this up because I just want everyone to be a little more critical of our X-rays. We've operated on 4.5. Everyone's focused on 4.5. Everyone's high-fiving. Oh, it looks great, looks great, looks great. But when this guy comes back in 2 years with 5.1 completely obliterated, or he comes back in 2 months with even worse back pain symptoms that are different than before, look at that 5.1 level and see if you see anything structural that's changed, because we're doing something there that we don't understand yet.
Is he also, do you think he's only 6 weeks out? Do you think, give him a little bit more time to rebalance himself?
Maybe, or that left hip of his may also be stiff and he's losing extension that's forcing him forward. That's why I brought that up in the first case. So again, we tend to be so narrow focused on the spine pathology of the index level, and we forget all the other variables that go into this.
Yeah. At the same time, I don't think you would argue to give him less lordosis at 4.5, or to, just fuse 5.1 at the index surgery. So it's like you raise hard questions, hard problems, but I don't know what the answer is.
We don't. I'm bringing this up so that we all think about it so we can eventually figure out the answer. So when I need my fusion done, you guys know what the right thing to do is.
Yeah, me too. But listen, Brandon, and
Good
this
job.
was great. And Steve, We really appreciate you doing this tonight. These were all great cases, very provocative cases. Not one answer fits all. And
Yeah.
we just appreciate it. And it's always the discussion that I think everybody learns the most from. So we thank you
Yeah.
for doing this and look
We
forward to
appreciate
having you
your
back again.
both of your time and your wisdom and appreciate you putting this on and having us. Thank you so much.
Yeah, thank you. It's our
Izzy,
pleasure.
Izzy, want to close it? Or do you already?
Sure.
Izzy,
Great spectrum of cases, stuff that all of us see every day. And I think one of the messages from tonight is if you do the job right the first time, it's going to go well. Have a good
Yeah.
night, everybody.
all right, everybody.